children and pregnancy, and then as soon as you get to be 23 or whatever, it's over. And there's more, I think, leniency on a type 1 child here other than the Medicaid child, who probably, really needs it.
Yeah.
I would like to add something. I'm J1 Frankie, endocrinologist also. I do CGM heavily in my practice. So there's some things that work very well for CGM, others don't. Even if it's a type 2 patient, and correct me if I'm wrong, even for type 2 patients who use insulin for mealtime insulin, it's easy to get. So anybody who's on multiple daily injections or MDIs, where they're taking a basal and a bolus, all CGMs are covered very well. Dexcom was first approved in 2015 for therapeutic CGM, for therapeutic mealtime insulin. And now I use Libre and Dexcom both equally. For Medicare patients, 1, they need to be on insulin, and 2, they need to have a data that they're checking 3 times a day at least for 2 months. So as long as you have that 3 times a day blood sugar log that you can fax, you can get the CGM approved. So that works well. But for all my pump patients, of course, there's a criteria for the pump, and as long as the C-peptide is undetectable for Medicare type 2, we get the pump covered.
Yeah, I think there's some payer differences. Certainly there's some, there's still a pretty significant drop-off from the use of CGM. The estimates are with a traditional CGM, about 25% will drop off within, I think it's 6 months. So the alternative of an implanted CGM, which is, a very small implantation, is it's relatively new. It's only been approved for a while, but whether that will help and will help with patient adherence, we'll have to kind of wait and see. And then the Libre is a little bit different. So it's not giving you the information, it's not giving you alarms and alerts, it's only giving you the data when you swipe it. So for type 1, a lot of people don't like to use the Libre because what you really want the CGM is to forewarn somebody that something's happening. But Libre is working on turning it into a continuous glucose prospective reading rather than just retrospective through the uploads.
Before we switch gears into motivating patients that Neal will help us with, can you just talk a little bit about the trajectory of how much more accessible technology is getting as the price points are falling so that it becomes more ubiquitously available?
I don't know if I could, that's a tall order. I would say, I don't know if the price point is necessarily falling. Certainly, the biggest change has been in the cost for strips. The price drive down has been remarkable, and to the point where many strip companies kind of exited the market. For CGM, they're at pretty much parity of what it is equivalent per day to use. So if you got a CGM and you change it every 21 days or 14 days or 7 days, it all turns out to be pretty much across the board what it would be for the daily amount, which is about $3 to $4 a day. And then the pumps, there hasn't been a lot of change in pump price, to be honest. There's been some relationships with some of the payers too, and then of course what CMS will pay for it. But as these automated systems are coming out, they're not adding more cost, at least initially, and saying it's the cost of the CGM and the cost of the pump, and all that algorithm in between is being given pretty much at no cost. So if you wanted to get, and I think it's going to be the same when the Tandem system comes out and the Omnipod system, but the Medtronic system is, this is the cost of a pump, whether it's got this capability, it's got that capability whether you want to use it or not. Here's the cost of the CGM, whether you want to use it to close the loop or not, the cost is all the same.
I just want to say that this is just a patient story.
Mm-hmm.
I mentioned to you earlier that my best friend in graduate school has a type I don't actually know which type diabetic he is, but he was in and out of emergency rooms and hospitals constantly, his whole adult life. It was really frightening to be around him, frankly, because he was always in a medical emergency. And when he started using the now very discreet, that was the difference for him, is when the technology shrunk to the point where he could wear it discreetly to monitor his blood sugar, he has never been back to the emergency room or hospital since. He's fine, because he can see what's going on with the technology. So it's a new age for diabetics.
Right, and I will tell you, probably the biggest joy as a pediatric endocrinologist is just saying, you know, these kids by the time they're 4 and 5 know numbers. They all do really well in math. I think they've lived their lives on numbers. Many of them become little mini chefs very early on because they want to control their food. It is, you know, and we educate obviously parents and families across the board. Schools have now adopted to all this technology, putting it on, putting it off, you know, who to call, looking at remote monitoring. The nurse can look at some of these CGMs in her office, doesn't have to sit in the classroom anymore. So, you know, it's doable from an information standpoint. I still think that the hardest part is, you know, getting through some of the barriers of wearing it and having somebody find out, and the cost. But it is, you know, and it's certainly much more acceptable, you know, across the board. I think Neal and I do a lot of international work, and probably the biggest difference, I would say, if I had to say what accounts for the difference between A1C outcomes here and maybe in Mexico for children, is that it's pretty much accepted that you can have diabetes here, and it's not, you know, something's wrong with you, I might catch it, and I don't want to be your friend anymore. In some of these more developing countries, it's still a stigma, and that really impairs people from managing their disease. So I would say, if I had to say what was the one thing that's really driven it, is we have destigmatized this as a chronic disease for children, young adults. I mean, nobody seems to care like they used to care in the old days.
How do third world countries accommodate to the escalating cost of insulin?
So they don't. So what, this last year we were in Ethiopia working, and we're actually in 2 weeks we're going down to Mexico. There's an international group called Life for a Child. It was started by some people in Australia. It was part of the International Diabetes Federation, which is the international umbrella group for all the different associations in diabetes across the globe. But pulled itself back out and is now part of Diabetes Australia. And what they do is, the drug companies have been very generous. Donations, the Helmsley Trust has come forward, the JDRF, the ADA, all working to have a pool of mainly regular and NPH insulin, so the insulin I have used for 30 years in this country in children. But they do get that for free. They're given strips for free, and you know, these are rural Ethiopian children who would otherwise succumb to the diagnosis right away. And what this group does is it trains a provider, it tracks the outcomes, it tries to advance things, it enables them to get an A1C once or twice a year, works with advocacy groups, and there are, you know, kind of international advocacy groups about getting more and more countries. Mexico pays for insulin, but they'll only pay for regular and NPH. To look at some analog insulin as well. And you know, it's kind of hard when you go to a lot of these countries and a family will tell you, you know, I can't afford any of this if it's not given to me. The choice is, do I feed the children I have and let this child die? And that's often what happens. Mm-hmm. So this has enabled these children to live. We gotta continue to try to do better so that they don't live early with complications. And children in Haiti, there's probably 95% of the children with type 1 diabetes in Haiti are on the program. And it keeps them alive, so there's a lot. But yeah, you every time you go someplace, you gotta put, your 1980s hat back on and remember how you did things.
Well, thank you.
Thank you very much.
Thank you for that informative and interesting presentation. And now carrying on with part 2, if you will be how we take technology and expand it into motivating people and helping improve outcomes, and also looks like we'll discuss some of the business aspects of this as well. I'm delighted to introduce Dr. Neal Kaufman, a adjunct professor of medicine from UCLA, and the co-founder and chief medical officer for Canary Medical. And again, he will be presenting the technology carrying on.
Thank you so much. We're going to switch gears, maybe 180 degrees.
Speak up.
We're going to switch gears, maybe 180 degrees, not necessarily talk about technology that Fran was talking about, but instead we're called digital therapeutics, using digital technologies to be able to improve patient outcomes. What I'm going to do first is just give you a small introduction of myself and the company. Hattie, on Friday, said we'll add 2 slides on the DPP, because I know some people are interested in that. That's not mostly what we're going to talk about, but I'm going to give you an overview.
Can you
of
just not use acronyms, please? So
the Diabetes Prevention Program.
Yeah.
I'm going to give you an overview of digital health, and then in the context of that, a newly emerging approach called digital therapeutics. What does that mean? Why are they different? How do they work? And then I'm going to give you an example. So Canary Health is a 4.5-year-old technology company. Our mission is to decrease the frequency and severity of chronic conditions, and we do that by using digital technologies to deliver evidence-based programs that we know work in person and have been proven effective over decades of research and practical use, and offer that to individuals. We work with health plans, healthcare providers, community-based organizations, and others. So why does digital DPP work? Diabetes Prevention Program was a NIH-funded, 3,200 subject, 27-site program published in 2002 that demonstrated that overweight sedentary adults, if they were helped eat better and be more active, were able to lose weight. By the way, they only needed to lose 7% of their body weight to improve their risk. And that with that weight loss and increased fitness, they're able to lower the progression from pre-diabetes to diabetes by 58%. It was published in 2002 and created a stir in terms of the sense of accomplishment that you could actually prevent type 2 diabetes. The dominant way that the CDC, the Center for Disease Control, chose to expand the diabetes prevention program was through groups. A research study was done at the YMCA, demonstrated that 15 people, 10 to 15 people in a group with a skilled counselor were able to get results very similar. We took a different path, and that was to look at whether you could deliver it in a digital format. The University of Pittsburgh faculty created the original diabetes prevention program. They had federal funding, and they funded us to build with them and then to test with them, and then eventually to market the first ever digital diabetes prevention program. The reason that digital works is that it's available 24/7. The level of engagement and coach interactions can be as much as the person wants or as little as they want. Some people would never join an in-person group. They just don't like to share their feelings. They don't want to be in public. Others would never join a digital program because they do want to be with other people as they work out their problems. Digital programs are easy to implement and administer by a host organization. The biggest challenge, and it's probably the secret sauce of all of these programs, is how to get somebody to sign up and show up. But once you've gotten them to show up, and I'm not underestimating the challenge of that, you're able to then have us or another company, there's a number of competitors that you're probably very familiar with, who have developed programs for the digital DPP to be able to deliver that. They also have the capacity of collecting data and the like. So just a very brief summary of our program. It's year-long. All the DPP programs are year-long. It has 16 weekly core, 8 monthly. All of them have 16 weekly, 8 monthly. It's a CDC requirement to be able to become fully recognized. You have to have planning, goal setting, monitoring, tracking. You have to have a coach. In our case, we use healthcare professionals exclusively. Some programs use non-healthcare professionals, which work well. We chose to use healthcare professionals because, contrary to what the diabetes prevention title sounds like, about 20% of our participants have type 2 diabetes when they enter the program. Their payer believes, and we've proven with them, that it's effective for someone with type 2 diabetes who doesn't have complications, but diet, physical activity, prescription is their core. We've had more than 50,000 users on the program, and it is fully recognized. A variety of commercial insurance plans pay for the DPP. Medi-Cal recently, state bill pays for it. Medicare pays for the DPP in person, in group, but not digitally. If you have questions, we can talk about that later. But I wanted to shift, because I really do want to talk about chronic disease. And unfortunately, we know that the epidemic of chronic disease persists, regardless of all the good work that people have done, the attempting changing that trajectory. More individuals are getting chronic illness, more of them are getting multiple chronic illnesses, and there's still much more that needs to be done. We need to improve the quality of the care that people receive. Most importantly, we need to drive deeper patient engagement so that they're more likely to want to do and be involved in their own care. And when you do that, you can make a major difference. Digital health, I'll explain my definition of that in a moment. Digital therapeutics, I'll explain that also, are really part of this movement to try to improve outcomes. So there are a range of digital health tools, and I like the word tools. Think of them as something that helps you to do something. So if you want to measure something, a tape measure is a tool. You don't expect it to do anything else, just measure, the distance. Now, maybe it does it in metric, it does it in inches, but it's not an intervention. So there's a range of tools, whether they're consumer mobile apps that you can purchase without any evidence behind them that people can use them, consumer wearables that measure your heart rate, your physical activity, connected biometric sensors. We heard Fran describe one obviously for glucose, but it could be for many other biometric conditions. Smartphone cameras that can take pictures of what you eat, that can be uploaded by a dietitian can look at it and can try to make an estimate, and perhaps someday be able to actually accurately reflect that. There are tools that are used within clinical care. There's connected virtual assistants for people in the home. You can have telemedicine visits, which is basically a visit transformed, where instead of you and me being in the same room at the same time, you're someplace and I'm someplace else. Other than that, it's really a medical visit. Obviously, personal health records, texting and email, and the like. Web-based interactive programs can be just tools, where they give you a little bit of information, or they can be something much more. So just to give you a sense, actually I'm going to skip this one to save some time. There's a range of digital apps. This happens to be a study done in England with about 1,200 apps that they looked at for chronic illness a couple of years ago, and you can see that the majority of them were either mental health and behavioral disorders, 28%, diabetes, 16%, heart and circulatory, 11%, nervous, 7%, musculoskeletal, 7%. A lot of different conditions. Again, these are the range of apps that you can get, and some of them have evidence, many of them don't. It's not surprising that someone builds something and then tries to commercialize it without having the kind of evidence that people in this room respect. And others really do have evidence. But again, they're a single tool. They're helping you do a single event. There's a new class of therapies. And I will just ask anybody in this room, how many of you ever heard the term digital therapeutic? Well, Fran has. That's It's a term that is about 3 to 5 years old, and the only way you probably would have seen it is if you happened to be reading investment summaries. I knew it was becoming something when for $5,000, if I chose to, which I didn't, I could buy a 50-page description of the future of digital therapeutics, find the company's name listed in it, etc. So it's becoming a common term, at least in the VC world, venture capital world, at least in investment world, and increasingly in digital health. So what are digital therapeutics? Digital therapeutics means that you're taking a digital approach, internet, text messaging, think of that as the digital approach, and you're using it to either replace or enhance a particular service. So they're research proven, they're evidence-based, they may or may not be regulated by the FDA. So for example, a digital service supports and improves patient habits and behaviors, it's independent of pharmaceuticals, it may have peer-reviewed evidence, it may not. Obviously, if you're trying to get reimbursed, you need evidence, but typically not regulated by the FDA. Don't think of it as at that level of medication. An adjunctive digital therapy adds value to an existing pharmaceutical. So improving adherence is an example of how you might add value. And that may require FDA approval depending on what the medication is, the closer you are to insulin, the more you need it. The closer you are to an oral medicine, perhaps the less you would need it. Then the third type is a drug replacement or enhancement. That's one in which the digital therapeutic is attempting, and presumably has proven if it's going to be effective or successful, that there's direct clinical benefit that can stand alone, and that's typically approved by and regulated by the FDA. So this is the famous RightCare triangle. And I want to shift gears and focus on one area that is part of the triangle. So protocols on the far right, or my far right, clinical pharmacist on the care team on the left, and then patient activation in the center. And what you'll see there is that it's critical, if you're going to be using traditional medications, that you focus on the patient, you focus on his or her health journey, you focus on what they're trying to do to improve their health, to get the health they need for the life they want. The health they need is relative to the life they want. And as I've gotten older, I realize there are things that I want more than others. And the health that I need to have to be able to do those things have varied over the decades. And so helping someone to understand that. So you look in here, in RightCare, I apologize if it's hard to read, stress reduction, medication adherence, healthy sleep, nutrition, physical activity, smoking cessation. It then has another line called evidence-based patient education, Project Dulce from San Diego, and then Stanford Patient Self-Management, which is the program I'm going to be talking about. They also talk about motivational interviewing and evidence-based media messaging. All of those are part of the toolkit in helping people to become more active. So I want to talk to you about a particular digital therapeutic that's called the Chronic Disease Self-Management Program. That's the name of it in person, and Better Choices, Better Health is the name of it digitally delivered.
Can you just stop for a moment and talk about the chronic disease self-management program that you worked on with Stanford and how that...
I will.
Oh, okay.
Don't do my talk for me.
Well, I just wanted to make sure that, that Kate Lord gets credit for this.
Kate's going to get all the credit she deserves, which is all of it. I want to step back before I do what Hattie's asked and have us think about what is a characteristic of any medical therapy, whether it's a digital therapeutic or medication. You have a target population. You have a mechanism of action, or at least a proposed mechanism of action. Sometimes we don't know, but often we do. It has an active ingredient, something that actually is what's causing the impact. There are contraindications, there's the role with other treatments, other side effects, other drug-drug interaction, for example. There are certain requirements for success that are on the patient. There are certain side effects that you're looking for, and certain outcomes. And so if you think about what I want to describe to you is the chronic disease self-management program's mechanism of action. So how many of you heard the terms, other than Fran, of increasing self-efficacy, or the term self-efficacy? Again, not a very common, I think 5 or 6 of you raised your hand. Self-efficacy is the belief we have in our own abilities, specifically our ability to meet the challenges ahead of us and complete a task successfully. It's different than self-esteem, it's different than self-worth, it's different than a range of other things that we think of as ourselves. It's the confidence that you can set a goal and accomplish it. And in a moment, I'll give you some data on why that's important. This is an idea that began in about the 70s. Alberto Bandura from Stanford was the one who discovered or defined this. It's at the basis of almost every theory of action and of psychological well-being. Is that if you're able to have increased self-efficacy, you'll do better. Another way to think of it is self-belief does not necessarily ensure success, but self-disbelief assuredly spawns failure. If I have the belief that I can do it, I shall surely acquire the capacity to do it, even if I may not have it at the beginning. This is something that you can get over time. Whether you think you can or think you can't, you're right. Henry Ford. Understanding that basic element of each of our lives. Do we have self-efficacy? By the way, we have self-efficacy varying across a range of things. You might have great self-efficacy about your role as a parent, but less self-efficacy about your ability to run as fast as you want to. So you could imagine a range of self-efficacies. They tend to go together, but if you're able to improve your self-efficacy, you'll improve things. And then one that I like the best is the little engine that could, I think I can, I think I can. You have brains in your head and feet in your shoes. You can steer yourself in any direction you choose. Dr. Seuss. So the bottom line is that if you're able to increase self-efficacy, and you have a mechanism of action for a digital therapeutic or for a therapeutic, you can make a profound impact. So what are people like who have a high degree of self-efficacy? I'm spending a lot of time on self-efficacy because I really think that's the key that's going to unlock a range of different approaches, not just the ones that we use, but how you approach patients, how you modify their behavior, how you help them become more motivated. People with strong self-efficacy believe that they can master things, they can take on challenges, they can accomplish things that are important to them, that they believe that they're able to recover from setbacks and disappointments, that they're able to self-regulate and able to cope better with their environment or with adversity. People with a weak sense of self-efficacy avoid challenging tasks. I'm just not going to do it because I know I'm not going to be successful. Why make me feel guilty again because I know I couldn't do it? They believe that tasks are difficult beyond their capacities. Can you imagine someone doing something that they think they can't possibly accomplish? Why would anybody in their right mind do that? They focus on their own failings, their own negative outcomes, and they quickly lose confidence in themselves. As that happens, their health gets worse. So examples of individuals with strong self-efficacy: a woman who's accepted a job in a role she has never performed before, but feels she has the ability to learn and perform her job well. A man who's had bad luck with relationships so far, but retains a positive outlook on his ability to connect with his upcoming date. An entrepreneur who pours her heart and soul into establishing her business, but quickly moves on to her next great idea when her business is hit with an insurmountable and unexpected challenge. A man who is struggling to manage his chronic illness, but feels confident that he can get back on track and improve his health by working hard and following his doctor's recommendations. These are characteristics of people with self-efficacy. The question is, can we improve people's self-efficacy? Are there methods that people can experience that can do that? So increasing self-efficacy has been able to demonstrate the things that we really care about in terms of outcomes for our patients. One is it accelerates behavior change. That if you increase someone's self-efficacy, you'll increase the rate that they can change their behaviors. Independent research demonstrated that it reduces depression, anxiety, and stress-related disorders, something I think we all imagine would be foundational, particularly people with chronic illness who have higher rates of depression, anxiety, and stress-related disorders. It can lessen perceived pain. It can slow cognitive decline. One of my favorites. I hopefully have high self-efficacy so I can slow my own cognitive decline. Diminishes social isolation. It increases participation in programs, and improves system navigation, meaning people are able to manage themselves within their program. So now to answer Hattie's question, what is the Better Choices, Better Health program? First, what are their mechanisms of action and what are their key characteristics? Just to give you a sense, Fran talked all about insulin, a number of delivery ways, the target population, people with diabetes. You can, I think, see that and you can read it. But if you think about, and if I could explain for you, the way that we use this within Better Choices, Better Health is that the target population are adults with chronic disease, that we use self-efficacy to increase their ability to self-manage their lives, that the active ingredient is the experience that they have within the application. There's no contraindications. It's adjunctive to traditional clinical care and case management. The person has to be cognitively intact, they need to have digital access, they need to be able to use email. It's not asking for a very sophisticated technology capacity, but email means that you know how to send a message, wait, and get another one back, so to speak. There seem to be no side effects, and it's got demonstrated improvement in outcomes. So Dr. Kate Lorig, about 40 plus years ago at Stanford, developed a program called the Chronic Disease Self-Management Program. It was a remarkable success. It's been used in 30 countries in 17 different languages, over 1 million people in person. And it basically is a 6-week peer-to-peer program where people come together for 2.5 hours a week for 6 weeks, 10 to 15 people who have chronic illness. It could be the same chronic illness, or it could be whatever chronic illness that happens to be brought together, with 2 peers who are facilitators who've been trained to manage the program. There's been hundreds of papers that have demonstrated the impact, and it's been evolving over those 40 years as new evidence and new information comes out. So again, increasing self-efficacy improves self-management. It does this through a number of particular approaches. It connects life priorities to health outcomes. helping someone see what's important to them, helping someone understand what would make a difference in their life, can make all the difference in their ability to self-manage. It helps with coping with emotions and depression.